So as in the previous days, we are about to showcase 6 presentations of health experts all over the world who have identified alarming issues that are deeply affecting the health of people on specific areas. These issues have been either underreported or poorly addressed, maybe until now. Let's see. The presentations have been taken from the Geneva Health Forum call for papers. 6 presentation reports on experiences in India, Guyana, Suriname, Brazil, Burkina Faso, Democratic Republic of Congo, Kenya, and Mali. Taking the lead in this discussion, we have a distinguished duo of moderators who will be dividing this session. The first is Blaise Genton, Emeritus Professor of Tropical Medicine at the University of Lausanne. He worked for 15 years in malaria endemic areas such as Papua New Guinea, Tanzania, and Uganda. He has done research on implementations of malaria interventions, especially when it comes to vaccine and drugs. Please welcome Blaise Genton. And now allow me to introduce our second distinguished moderator. She is a scientific collaborator and coordinator for the MAS in Public Health at the Institute of Global Health in Geneva. She worked for 20 years in malaria endemic areas in Cambodia and northwestern Thailand, doing humanitarian work and clinical research. Please welcome Verena Carrara. I'll let the floor to you both.
So good afternoon, everybody. We don't see you very well, but I hope you will enjoy the 6 presentations of this evening. The first one will we will travel with them in India, and let me introduce Shrikant Nema as our first speaker. Shrikant Nema is a project research scientist at the Indian Council of Medical Research National Insitute of Malaria Research, based in New Delhi, and his research focuses on understanding better the molecular epidemiology of malaria parasite and finding potential marker for point of care diagnosis. And himself and his group has set up India's first malaria slide repository to support training activities for malaria microscopists in order for them to get the national competency assessment necessary for their work. And he's done a lot of work that has been awarded the Professor M.B. Mitzart Award in 1922 for best publication made in India. So, Mr. Nema, the floor is yours.
Thank you very much for the introduction. First of all, I would like to thank GHF for providing me opportunity to present my work here. Can I have my presentation? Okay, that's it. So the title of my presentation is Undetected Mixed Infection, Plasmodium Infection May Increase Vivax Malaria in India. It's one of the challenges in malaria elimination. So as we all know that malaria is a significant tropical disease which is caused by Plasmodium, and it is transmitted by the mosquito. So we have, out of 5 Plasmodium species, 2 are very dominant in India. They are Falciparum and Vivax. If you look at some of the statistics, in 2022, the total 249 malaria cases were recorded in worldwide, in which India accounted 3.3 million cases. So in India, the contribution of Vivax is 46% and PF 53%, and other species, Malaria-Ovale, is 1%. So the government of India has aimed to eliminate malaria by 2030, but the goal is depend on different pillars like the diagnostic treatment and malaria vaccine, and the most importantly the surveillance. So diagnosis hold the key. If we for the right treatment we need the correct diagnosis. So major burden of the malaria in India exist in rural and tribal populations. So mainly the diagnosis is done by microscopy and RDT kits. But both these methods have limitations and their own advantages. Like RDT kit has HRP2 deletion, which gives the false negative results, and the persistence of HRP2 in the blood after the parasite get clear, it gives the false positive. And the RDT and the microscopy has its own limitations, like it requires the good quality of slides and the trained microscopist, which is very difficult to get in these rural and tribal areas. So one of the study reports that there are more than quarter of malaria cases which are missed by microscopy. If you look at this graph, this yellow line indicates that the annual blood smear examination. So as much as we do the blood smear examination, the number of cases get decreased, because is here, so the whether elimination target can be achieved by relying upon the result of microscopy. So in order to find the solution, we have re-diagnosed microscopically confirmed P. falciparum cases by PCR to ascertain the presence of P. falciparum and other human Plasmodium species. So we collected the samples which were previously used in TES study, which is recommended by WHO, therapeutic efficacy study, which was conducted in 2014, 15, 17, 19, 20. So we collected around 1777 samples from the 14 sites, which are in 9 states. And these 9 states contribute approximately 80% of the total malaria cases in India. So these cases were microscopically confirmed, mono P. falciparum, and they were treated as per the national policy. And then we collected the DBS, we isolated the DNA isolation, we did the DNA isolation, and then PCR and the analysis. So you will see here, in the 2017, the highest mixed infection was found. And if you look at the state-wise prevalence, Telangana district has the highest malaria infection, mixed infection. And if you look at the age-wise, 4 to 8 group, 4 to 8 years of age group has the highest mixed infection. And there was no difference, much difference found in the gender-wise. So overall, 18% of the mixed infection was recorded. And so it means that we have missed these mixed infection and we have treated wrongly for the P. falciparum. So where do we stand and what we have to do? So surveillance is considered as one of the core intervention for malaria elimination. So we need to strengthen our reporting system, and data should be stored in a fragmented manner. So this is one of the papers we have published in Trends in Parasitology in 2021. So here the SPO, this is the digital system which shows that in rural and tribal area, we can achieve the malaria elimination. So there are different stages like state program officer, district malaria officer, block medical officer, and ASHA ANM, who are the field worker. So they all should report to the malaria dashboard. And they can finally have a good database so that the underreported and the case should not be missed. So they will have one database and they can access further. So I wanted to share here 2 successful examples. One is the MEDP, which is implemented in Mandla district and Madhya Pradesh, which has achieved around 91% of reduction in malaria cases. And another one is Daman. It is implemented in Odisha. So they have applied all these strategies. If these strategies come together, we can achieve the malaria elimination. So it is possible. So the training of microscopists is another important thing, because as the cases are going down, we need to train our microscopists to meet the required competency standard. And they can also support the local health worker, laboratory technician, and so that they can maintain their skills and expertise in malaria diagnosis and surveillance. So in NIMR, we have established this malaria slide bank. So it is around, we have 20,000 good quality slides, which are positive and negative, which is quality control checked by WHO certified level 1 microscopists. So we give them these slides to the regional office, CHC and PHC level, for the training of the microscopist. So in summary, I would say the molecular test is very important, which should be implemented in the field setting, and regular training of the microscopist at CHC and PHC level is very important. If we could integrate these microscope with the AI tool, it would enhance its effectiveness. And obviously the community engagement and education is very important. And we have to assure that the malaria commodities are reaching at the time, and local and focal measures should be adopted. And obviously this would not be possible without the support of political commitment and funding. Thank you.
Thank you, Shrikant Nema. I think we have time for a few questions. Is there any question in the room? Well, maybe I do have one question. You're mentioning that molecular markers should be implemented as a complementary tool for diagnosis. How would you imagine implementing that for optimizing the system? Because obviously it has a cost. It may not be always useful. So how would you imagine optimizing the use of molecular tools?
Yeah, we need to work on these. We should have a handheld device. And nowadays, the TrueNot is one example, which is quite success in the field. TrueNot we can implement in the field. So, because in these, I'm talking about the area where resources are very limited. In rural and tribal areas, only we do microscopy and RDT. So these TrueNot and all we can apply, we can implement to the field. And we have done the trial in the field, and we got the result that it is quite successful. So TrueNot is one example, and other device we have to work on, like how we can minimize, because PCR is not possible in the field setting. So we need to have a small device which we can do in the field settings.
Thank you. Is there any more question in the room? If not, thank you very much for this presentation.
Good afternoon, everybody. Not a lot of people, but quality people, it seems. So I would like to invite Dr. Hélène Tréhard. She's PhD students working on vivax malaria elimination in French Guyana, and she's doing her thesis in Aix-Marseille University. I guess she will speak in English.
Yeah, I can speak in English, but I'm sorry, the slides are in French. So hello everybody, I will speak today about one of my PhD topics, and we will focus on testing and treatment strategies in low transmission of Plasmodium vivax. And I will show you some results from our work in the field to help to choose the right tools to use in test and treat strategies. So just a short overview of French Guyana. So French Guyana, it's a French overseas territory located in the north of South America, between Brazil and Suriname. And it's nearing elimination with a very low incidence rate, 1.17 per million inhabitants. And most of the cases are due to Plasmodium vivax, of the recorded cases. So we struggle, because of Plasmodium vivax, we have the specific struggle of relapse and also the need of radical cure. So which intervention to reach elimination with Plasmodium vivax? So if we look at WHO recommendation, it starts with a reinforcement of classical strategies, such as improving access to diagnostic and treatment and vector control, especially for the population which are far from the health system. And we also have some specific strategies to target the asymptomatic reservoir, which is important in elimination phase. And the idea is to combine the treatment of the acute phase and the radical cure after a J6PD test. So we have several strategies. The treatment targeted on at-risk population, mass treatment targeted on at-risk population. We also have reactive testing, treatment, and vector control. And we have testing and treatment at the point of entry. For now, testing and treatment is not recommended because we don't have a lot of data on that strategy, and also because of the number of people you need to screen. You need a test which is usable in the field and which is sufficiently sensitive to diagnose asymptomatic carriers. And we lack that kind of test. And we also cannot diagnose hypnozoite. But we have new promising tools in development. We now have serology, which can diagnose recent infection. So we could use it as a proxy of the presence of hypnozoites. And we also have, since a long time, the PCR to detect the asymptomatic cases. And for both tests, research are in progress to try to have a rapid test version, the field version of those tests. So the idea of that study was to, in prevision of all those new things, to look at what it would imply to use those diagnostic tools in TAT strategies in the field. So we use the data of a PCR TAT, so a TAT using PCR, implemented in French Guyana, and we look at what population we would have targeted using the other diagnostic tools. So that strategy was implemented at Saint-Georges-de-l'Oyapock. It's on the border between French Guyana and Brazil. And it was implemented between September 2017 and December 2018. And for each year, we did a survey. And for each survey, we collected PCR, RDT, and serology. And we only treated the PCR or RDT positive cases. The serology was collected only for the purpose of research. So we had around 1,500 participants among the 4,000 inhabitants, but only from 12 of the 15 neighborhoods of the city, because we focused on the neighborhoods with a higher prevalence of malaria. And for each strategy, we describe the group targeted by the treatment, the number of participants targeted, the number of vivax carriers that we would not have detected, the number of potential hypnozoid carriers that we would not have detected, and also the percentage of the population with contraindication to primaquine, such as deficits in J6PD or pregnancy. And so we looked at our strategies that we implemented, the PCR TAT, but also what it would have been with a serotat, so a TAT strategy using serology, RDT TAT, a TAT strategy using RDT, and a sero-PCR TAT, a TAT strategy using both serology and PCR. So if you have one of those two tests positive, you get treatment. So it's a pretty young population compared to the French population, because the median age was 18, with 53% of women. It's also a poor population, with 38% of the adults without any activity, 21% doing informal job, and 22% living from hunting, fishing, or farming the traditional way. So if we look at the results in our study among the 1,500 people, we had 90 participants positive for PCR. So we treated all those participants with the treatment against blood phase, acute phase. But we missed 282 participants which were seropositive, so potentially hypnozoid carriers. They didn't all receive primaquine, as 13% had primaquine contraindication. If we look at what it would have been with serotat, we see that we would have treated 390 participants, we would have targeted, but we would have missed 21 participants with a positive PCR, so vivax carriers. And among those 390 participants, we also had 13% contraindication with primaquine, meaning that we could have treated only 340 participants with primaquine. And looking at those people, we know that around 25% of them already get treated, might already have been treated, because they knew that they had a malaria episode in the past 9 months, so they might already had primaquine for their episode. And lastly, if you look at the RDT-TAT strategy, we would have targeted only 12 participants, so we would have missed 72 participants PCR positive and 332 seropositive potential hypnozoic carriers. I will skip this one. So what we can say about that, in our data, the RDT-TAT strategy was clearly insufficient. So we can explain that because it didn't catch all the asymptomatic carriers. For the PCR-TAT and serotat in our study, it was complementary strategies because none of them catch all the participants that the other one catch. And regarding feasibility, so as I said, it's a bit early to use those tools in the field in practice, outside research, because serology and PCR are not easy to do in routine, in daily life, but tools are in development. What it emphasizes also is that we need sensitive and specific tools. Sensitive because with that serology, in our study, we chose to have a serology more specific and less sensitive. So it might be one of the reasons why we missed some PCR positive. But it might be other reason also. So it's something we need to explore before using just serotat. And it also should be specific because with that kind of strategy, we want to avoid overtreatment because we don't want to do like mass drug administration. We want to focus only on a specific population. The other interesting result is a high percentage of primaquine contraindication, around 13%, and that percentage need to be taken into account when we design a TAT strategy to implement, just to be sure that it will not make the intervention fail. And this needs to be maybe modelized to know how many people we need to target to be effective. And also, we also have the issue of adherence with the primaquine treatment, and also in French Guyana, a lot of issue with logistical delivery of primaquine to consider. And finally, the limit of that serology that we use is very effective in low transmission setting, but it's less effective in moderate to high transmission setting. And in our study, even if the transmission was not that high, we saw that the median age of the population of seropositive was higher than the median age of the population with PCR positive. And it's a risk of that serology that can catch people with a more malaria episode and not necessarily a recent episode if you are in a context with more transmission, like moderate transmission. Thank you for your attention.
Thank you very much, Hélène. Is there any question? Yeah, there is one question there.
Thank you. Nice presentation. So I want to understand, I might have missed two things. One is what made you feel that the serotat is a marker for hypnozoite? And secondly, what were the contraindications of primaquine? Was it G6PD? And how did you treat those patients?
I'm not sure to have heard the first question. But for the second question, the contraindication to primaquine were GCSPD deficiency and pregnancy. And during the field study, it was also breastfeeding. But I didn't use breastfeeding for the presentation because I didn't get the data about breastfeeding for other people except those with PCR positive. And GCSPD deficiency, it was assessed by a test. At that time, it was not a field test. It was not a rapid test. It was a test done in a lab. So we also had delay to administer primaquine because we needed to wait for the test result. And then in French Guyana, we also need a specific authorization to get primaquine, and then we can give it. So it's longer. And for the first question, I didn't hear it.
Can you repeat your question, the first
sorry.
question?
The first question was about the serotat. You mentioned that it was a marker for hypnozoid. So I was wondering, how is it specific for hypnozoid?
It's more like a proxy because with that serology, the people with seropositive results we can say that they had malaria episode in the past 9 months. We don't know when, but it means that you had a recent infection. And the idea was to say, okay, if you had a recent infection and you don't know it, if you didn't get treatment, you are probably hypnozoid carriers because you didn't get any treatment. So it's not like you are sure, but normally it's like a proxy to, it's the best, it's because there is no other way to know. It's just another way, like another option to try to estimate who may have hypnozoids. And it's because in French Guyana, we have a lot of asymptomatic cases. In that study, the PCR was positive for around 7% of the population, and among them, 73% were asymptomatic. So we know that a lot of people will have malaria episode without knowing it. That's why.
Thank you very much. I think we have to go on if we want to be on time. Thank you very much, Hélène.
So our next speaker is Dr. Maëlys Douin, working also in French Guyana. She is a professor in public health and a medical doctor. She's worked with NGOs in Haiti and in Africa, and she's now working for 10 years in French Guyana, running an interventional research project aiming at eliminating malaria among hard-to-reach and mobile population, and in particular in gold miners. And she will present the results of her work in this presentation. Thank you.
Thank you very much. Yes, so we will stay in French Guyana, but we will change the population. Now we will talk about the population of people working in gold mining, and especially in illegal gold mines. So, I use it? Okay. Hélène already presented you French Guyana. It's a French territory in South America, so it be a little bit curious. And we share borders with Suriname and with Brazil. And the territory is mainly covered by the rainforest. We have to imagine that French Guyana, it's 2 times the size of Switzerland, and it's really only rainforest, and it's only 300,000 inhabitants on this territory. So you can see that it's really a virgin forest, we call that. But we also host the European Space Center, and we send the rockets, Ariane rockets, maybe you know. And the soil is really rich in gold, so that attracts a lot of poor workers from the region, mainly from Brazil. And we estimate that there are 10,000 of people working illegally on the territory. So it's a huge territory covered by rainforest, the borders are rivers, and there is a lot of migrants entering the French territory. And we feel in 2013 that the data from the surveillance system were not really perceiving the malaria transmission within the gold mining sites. That's why we implemented a cross-sectional survey specific to understanding the epidemiological situation of malaria within the gold mines. And among 421 gold miners, we found a malaria prevalence of 22%, mainly falciparum, a lot of asymptomatic carriers, and they use self-medication when they experience malaria symptoms in the forest. So due to their high mobility, two challenges were presented. First, the risk of artemisinin resistance of P. falciparum due to bad use of artemisinin derivatives, and a risk of malaria propagation in the region due to their high mobility. But that said, what we can do for thousands of gold miners in a very huge area, very difficult to access. We cannot hire community as workers, as done with, in Suriname, for example, because on the French territory, someone who is not a medical doctor cannot do a diagnostic or give a treatment. And there is also geographical constraints. Sometimes we need 5 days by boat or by foot to access one site. It's very far away. And there is police operation to fight illegal gold mines. So it's very difficult to intervene between the police and the population. That's why we invented a new strategy. We call that Mala Kit, Mala for malaria and kit, because it relies on a kit for self-diagnosis and self-treatment. So we decided that if we cannot access that population directly, we have to give them the means to self-diagnose and self-treat in case of malaria symptoms. We distribute that kit in the two borders with Suriname and Brazil for people entering to the French territory for gold mining. And the people can use it when they experience malaria symptoms and too far away from the health centers. And when they go back to a distribution site, they can have a refill or a replacement of the kit. Each kit contains 3 RDTs, 1 complete treatment with artemether lumefantrine, and a single dose of primaquine just to decrease falciparum transmission. We also put paracetamol in order that people who have fever but the RDT is negative, they can have something to take to decrease the fever. The distribution sites are on the two borders, and we hired community health workers who stay all the time on these cross-boarding points in facilities where they reach the gold miners before they enter the forest. They are from the community of gold miners, meaning mainly from Brazil, or at least speaking Portuguese. We developed a lot of training tools, information and education tools within the community, a phone app application, videos, drawings, everything for the people really understand how to use the kits. The people have to perform an RDT in front of the community health workers to prove that they correctly perform the test and understand how to read the results before receiving a kit. And they also receive the mosquito nets. It was a collaboration with the 3 countries, Suriname, Brazil, and French Guyana, a lot of actors from researchers, NGOs, or health institutions. Because from the beginning of the project, we decided that if it was successful, it doesn't have to stay a research project, but it should be included in the malaria program in the region. It was a research study with cross-sectional surveys before and after, and the collection of data all along the project, and qualitative surveys, and the safety data also were collected. Finally, during 2 years of the intervention from 2018 to 2020, we distributed 4,700 kits to 3,700 participants, meaning a third of the target population. 70% of the kits were correctly used, so for us it was quite good, because in France, for example, for antibiotics, it's something like 30% of the people who take the antibiotics for 5 days correctly. And before and after, the cross-sectional survey showed that the behavior changed. So we increased the use of RDTs, or at least a diagnostic tool, before taking ACTs and certified ACTs. In the meantime, the prevalence really decreased from 22% on the Surinamese border to 5% on the Brazilian border. And the proportion of falciparum really decreased as well. And now we are mainly facing the problem of vivax, as Hélène presented before. We made several modeling. It's a work of Jan Lambert, who finished his PhD now on this topic, to try to evaluate how malachite, what is the impact exactly on malachite on this modification of the epidemiology. So using different kind of modeling, like interrupted time series or here SIS, we show the same results, meaning that malachite increase the diminution of malaria transmission in this population. We didn't have any concern regarding the safety. We had monitored 1% of the kit were resold, and no ethical problem during this project. So, of course, it's a non-experimental design. It's a pragmatic design. We don't have so much kit use report because a lot of people use the kit in the forest but do not come back to explain how they use the kit. It's a declaration also about how they use the kit, so it's a bias. The question of the causality is always very complex in that kind of intervention, but in the same time we show that we have a better access to diagnosis and treatment, a good kit use, no problem of safety, and probable impact on the disease. So in our opinion, it would be interesting to think about how to use that tool in other contexts and even in our own region. So the malachite strategy is already integrated now in the National Malaria Program in Suriname. It's ongoing in French Guyana. It's quite long because we have a lot of regulatory issue, but normally in few weeks we should be able to distribute malachites on the French territory and not only on the other side of the border. Would be great. And we are also thinking how the strategy could be transferred in other contexts. So it will never replace a control strategy at a national level for sure. It's only maybe for some specific population which are not reached by other strategies, control strategies, maybe that could be useful. So we wrote an article, it will be published in Malaria Journal in the coming days, where we report the core principle of that strategy and how to adapt it in other contexts. We are already discussing with some researchers or institutions from different countries who are interested in maybe trying that malachite strategy for specific population in Colombia, Brazil, Guyana, Senegal, or India, but maybe it could be useful as well. Here you have our website, malachite-project.org, and you have all the information about the project, all the communication and training tools we developed. We also have a link with all our publications. I will put the link with the next one for the transferability in the coming days. And my email if you need more information. Thank you very much.
Thank you very much for this very interesting project on innovation on how to reach hard to reach population. Is there any question for Maëlys? Yes, in the back.
Thank you. It was a nice presentation. I want to understand what were the difficulties faced by the participants. Was it a migratory population? And how difficult was it to, maintain the quality of RDTs in that temperature and environment?
Thank you for your question. So for the RDTs, we choose the RDT who proved to be efficient until 40 degrees. So it was not a problem of storage, even if the rainforest. And we put in pouches, which are in plastic, so it's not very ecologic, but it's waterproof. So it's useful in our context. And for building the trust with the community of gold miners, so it was really relying a lot of community health workers who do outreach activities, meaning going to meet the population, to explain who we are, why we are doing that, why it's really important, and with the use of different tools like videos explaining also the problem of malaria and how to use the kit and why it was important for them. And they had a really huge interest in that project because having malaria for them on the gold mines, it's really it's really bad for them for two reasons, because they are sick, so it's not really comfortable. And the second thing is it made them not able to work, and they are here to work and to earn money, at least gold. So they were really interested to be able to self-care.
One more question in the front.
Thank you very much for the nice presentation. It's extremely inspiring to see, how you can think of other ways to reach the target population. I'm not sure you mentioned the cost of the kit and who's actually funding that, and do you foresee for all the countries that you cited, Senegal, India, etc., if you already have an idea of who's going to finance this?
Thank you for this tricky question. So in our context, we could buy the drugs through Suriname and Brazil. So we had a low cost for the drugs, meaning like for ACT, it was like $2, something like that, and $1 for each RDT. So with a plastic pouch, in total it was $8 in our context. Then if we continue, for example, to distribute malaria kits on the French territory, ACT in France are 40 euros for one tablet, for one complete treatment. So it will be a different cost. If you do that in Senegal, you can also consider to have a less costly pouch, because you can maybe do a pouch locally with a network of women, for example, who can make them with fabric. So the price will depend of the place where you are implementing the strategy. Then for the funders, in our context, it was many European funds, because the sponsor was in France, so we were able to ask for these specific funds. For other countries, that depends. Sometimes Global Fund is interested, sometimes Gates. We are discussing in Senegal also with PMI. WHO can maybe cover just some parts, but for now, it's not sure. But it will be a very important question, because what I heard is that our strategy is a low-tech strategy. And what is fun now to fund in malaria is high-tech. It's you are doing innovation with a new tool, something like more fancy than just plastic pouches. With RDTs, it's too simple for the funders, actually. It's not so sexy. So we are, yeah.
Thank you very much for this presentation again. And
now I would like to call Dr. Julian Merz. He's postdoctorate at the University of Zurich at the Institute of Biomedical Ethics and History of Medicine. And he will tell you what he is thinking of and doing.
Mm-hmm. Yeah. Thank you very much, Blaise, and thank you very much, everyone, for having me today and giving me the opportunity to speak about my research. So, just to tell you a bit about my background. So, I'm a physician, lawyer, and bioethicist, and I'm working as a research fellow at the University of Zurich, and primarily working on legal and ethical issues coming up in the context of genetic engineering. And that is basically the link to malaria that I have, because, oh, yeah. Thank you. I hope you heard what I said. Okay, fantastic. Yes, so I'm primarily working on legal and ethical issues of genetic engineering, and that is basically the link to malaria that I have, because of course genetic engineering is often considered one of the most attractive and most promising routes basically to completely eradicate malaria through this pathway. So there are many different pathways which are examined there, but one of the pathways is basically eliminating malaria-carrying mosquitoes. And I'm going to quickly talk about the ethical considerations coming up in this context. So this is still work in progress. So I can't present final results today, but I'm going to present the results of a scoping review, and I'm also going to present a bit about future directions basically for action in this field. So I don't have any conflict of interest to declare in relation to my participation in this event or in relation to the presentation that I'm giving. So just as a quick introduction, this topic of genetic engineering technology being used for eradicating malaria is basically everywhere. And so if you look into the popular press, I've put some examples there from The Guardian, CNN, Economist, but it's basically in all newspapers, they have some articles covering this topic. And of course, so these articles have been published over the last 6 years. So really a lot of interest basically on the side of the public because of course the perspective which is presented here, the perspective of eliminating malaria through genetic engineering is of course a very exciting one. And so just to give you a quick background, so the first research article which was really published, which described an approach how to eliminate Anopheles gambiae mosquitoes through genetic engineering was this article that I've put up on the slide, which was an article published in Nature Biotech by Kuros Kuru and colleagues, which described basically the approach. So the approach that they took was basically modifying the double-sex gene of Anopheles gambiae. And just to give you a quick background, so the double-sex gene is basically a gene which can be spliced in two different ways. If it is spliced in one way, it leads to a female phenotype. If it is spliced in a second way, it leads to a male phenotype. And basically what they did was modifying this gene in a way that it can only be spliced towards a male phenotype. And then, of course, they also inserted a gene drive, and that basically led to an Anopheles gambiae population which only consisted of male mosquitoes, and of course that led to the extinction of this population in cages. So they didn't try it in free nature, they only tried it in a caged mosquito population. But of course that is a very exciting approach which might be put into practice and into nature very soon. So just to explain very quickly how a gene drive works. So when I told you, so they modified the DNA of these mosquitoes basically to exclude this alternative splicing and basically to introduce only splicing towards the male phenotype, your first reaction might be, well, if I look at Mendelian genetics, that shouldn't have a big effect because the mutation will only end up in a couple of mosquitoes in the end. But what they did was basically introducing a gene drive, which is quite simply put, a mechanism to ensure that the mutation will accumulate in the population and at some point will appear in every offspring of the initial mosquito into which the genetic modification has been put in. And the way to do this is basically so, of course, you have two chromosomes like malaria mosquitoes have of every, so there's two chromosomes and one coming from the father, one coming from the mother. And basically what they did was introducing the genetic modification into one chromosome, but also inserting basically genes which would encode a guide RNA and an endonuclease, which would basically code for a CRISPR-Cas9 system, which would modify the second chromosome and basically cut the second chromosome and would lead to homologous recombination repair, which basically means that if there is a cut in the second chromosome, the mosquito basically just takes the first chromosome and copies basically elements from the first chromosome into the second chromosome. So the effect was basically in the end that the mosquitoes had the modification in both chromosomes. And of course that accumulates over time and into the offspring. And if you look onto this slide, so on the left-hand side you have the normal Mendelian genetics. So basically, if you wouldn't introduce the gene drive, then of course it would only be a very limited number of the offspring who would have this mutation. So you would have quite a high number of female offspring as well, so that wouldn't lead to extinction of the population. If you look into the right-hand side, you see how it worked out in practice with the gene drive, that the gene drive basically accumulates over time, the mutation accumulates over time, And basically that leads to a situation where really this genetic modification accumulates in all of the offspring of the initially modified mosquitoes. And that basically means that in the end you could end up with an entirely male Anopheles population, which would of course lead to extinction. And that was of course what they did in their cage experiment. So this article has been commented on a lot in the popular press, but then also in bioethics. And first thing we have basically done is doing a scoping review, just looking at the literature, which has been published here. And I'm not going to go into too much detail here, but just to tell you, when we look at the literature, so there's a lot of research ethics literature published on this topic, which might make some sense because, of course, when you look at the practical issue, what comes first is basically getting this out from a cage setting towards a nature setting, so rolling this out in nature. And that has been discussed a lot, how you can basically translate these findings from the experiments being conducted in caged Anopheles populations towards basically field trial settings. That has been a big topic. Other public health ethics topics also discussed a lot. And here you can basically see the primary ethical issues which came up in the literature when discussing this. So biosafety, environmental impact standards has been a big topic which has been discussed, which is quite clear basically, which is of course discussed in the context of all genetic engineering interventions, but of course in this one in particular because the potential impact is to some extent unpredictable. So in the end it will always be a balancing exercise between, on the one hand, eradicating Anopheles, which might lead to the eradication of malaria, and on the other hand, the potential side effects, the impact on biosafety and also on the environment, which we are not 100% sure about at the present time. Another topic, community involvement, particularly when it comes to open field trials, so how communities where these genetically modified mosquitoes would basically be introduced into nature. How can communities basically be involved in research design, but also in the rollout of these interventions? Transparency and trust, a big topic coming up. Harm prevention, of course, control, compensation issues, a big topic. Then, of course, need for international cooperation, a very big topic. And of course, a big topic, ensuring access to genetic engineering technologies in this context, because you might know very well that CRISPR-Cas9 technology is heavily patent protected. So you have more than 7,000 patents applying to some sorts of CRISPR or to Cas9 proteins. So that is basically a big IP landscape here. And of course, there comes up the issue of ensuring basically international cooperation and ensuring that everyone around the globe has access to this. And if I talk about this, you might also remind all the debates which existed out there in the context of COVID-19 vaccines were, of course, also this topic of ensuring access of everyone basically to this technology and to this innovation was a big topic, and I think it will again be a big topic in the context of genetic engineering and for malaria and for eradicating malaria. Next topic, one which is rather conceptual and theoretical, which might not play out that much in practice. Are we as humans entitled to just eradicate a species? So are we just entitled to eradicate Anopheles species? That is also a topic which is much discussed in the literature. Informed consent in open field research, a big topic. Who should consent? How do you basically inform people? What do you do if some community members might not be okay with, for example, introducing genetically modified mosquitoes into their environment, etc.? So that's also a big topic. And then, of course, when we think beyond malaria, how do we designate basically disease-carrying or invasive species for elimination? Because, of course, you can use this technology pretty much for eradicating any species. So this could be used for eradicating, for example, dengue fever, but it could also be used for just eradicating invasive species. So there's a big use in practice, and of course there needs to be some consensus on how a species could be designated basically for extinction through genetic engineering. So to conclude, basically, I think there needs to be a big discussion, there needs to be a global discussion on this topic, and I think it needs to be a proactive discussion. And that, I think, is a very crucial point here, because right now the impression that I have, what we saw in the context of, for example, COVID-19 vaccines, is always that you have some innovation coming out and then ethics and regulatory standards are to some extent lagging behind. So that shouldn't be the case here because, of course, more lives could be saved if these issues are sorted out before the technology is really ready for rolling out in a nature setting. So I think it is essential basically to address these issues right now and to come to a global consensus on these key issues which exist here. And I've put some of them here: risk-benefit, safety standards, biosafety, environmental safety standards, community involvement, and also global cooperation, and this global access issue which comes up. And of course, when we look at the literature, some key open issues are which residual risk is acceptable regarding biosafety and environmental protection. And the other one is, of course, can we use this for any organism, or is malaria a special case because of the global burden of disease, because of the many deaths attributed to malaria every year, or can we just use it for any, for example, disease-carrying organism, or even for invasive species, which might not even carry human diseases, human pathogens, but might just harm humanity in other ways. So I think that is also a big topic to be discussed, and I think also an essential topic to be discussed, because I think in the long term, genetic engineering will basically give humans the power to create the extinction basically of any species. So it can basically be used to extinct any species, including humans. And of course, that is an issue which should be addressed beforehand and which raises huge ethical implications. So thank you very much for your attention. And now I'm looking forward to your questions, comments, and yes, so I see quite a couple of questions coming up there.
Thank you very much. Very important that ethicists work hand in hand with researchers. I see a lot of questions. We have time for 2 questions if they are very short and the response is very short. Otherwise, it will be 1.
Thank you for, that's a good one, a good job. My advice, is it not better for us to concentrate on creative vaccine for malaria than trying to modify Anopheles mosquito? Supposing that mosquito becomes mutates into another organism that will be more hazardous. I'm just thinking that I would prefer a situation where, because I come from Nigeria where malaria is a problem, vaccination should be the target than genetic engineering that will create another something that will cause problem for us. Thank you.
Thank you very much for the comment. And it is indeed very important to have these conversations. And I think I found this point that the previous speaker has made very important, that right now, of course, a lot of research funding is going into innovative approaches. And I think, of course, genetic engineering is one of them, because it is, let's face it, very fancy. It is very innovative, uses new technology. And of course, very, very promising in the end for malaria, but also for using it on other diseases, for agriculture, basically, etc. So you can use it potentially for a lot of different purposes. I think what you rightly says, there needs to be some balancing of resource allocation in the end. So on the first, in a first step, basically, consensus on how best to allocate resources. So which priorities do we set between these very high innovation attempts and other approaches, basically. And then, of course, basically deciding which programs should be funded in the long term. And I think that is also a big debate which should take place, which isn't taking place that much right now, and which isn't really unified. And I think that is an important issue. And I agree that vaccination is probably also a very, very promising approach, and might be, yeah, I think they all go hand in hand, the approaches. So you have, of course, these very high-tech, high-innovation approaches which are promising to solve the problem altogether. You have other approaches which are solving problems which arise right now, so which are more practical in the short term, etc. So I think you need all of them basically for a great malaria response. But I think we need discourse on how to assign resources between them.
Thank you very much. In the interest of time, I propose that you ask your questions afterwards to Julian. Thank you very much. Thank you.
Thank you very much.
Let me now introduce Katia Alil, who will talk about another vulnerable human group, pregnant women and their newborn. So Katia Alil is Associate Director at Medicine for Malaria Venture here in Geneva in the advocacy team, and she has a crucial role in that group, helping find new funding opportunities and enabling policies for MMV works to happen. Prior to join MMV, she worked in a number of communication and advocacy positions in the United Nations agencies and also in private partnership. And so welcome, Katia, and the floor is yours.
Hi, everyone. I'm delighted to be here, and thank you, Verena, for that introduction. So I'm just going to give you a bit of background on Medicines for Malaria Venture. It's a product development partnership that works with partners all over the world to discover, develop, and facilitate access to innovative and affordable anti-malarial medicines. So in this presentation, I'm going to tell you a little bit about MMV's Malaria in Mothers and Babies initiative. Now, we call this initiative MIMBA for short, and MIMBA means pregnancy in Swahili. To connect this to the topic of the day, which is malaria elimination, we're not going to achieve a malaria elimination unless we reach all populations at risk. And among those populations who are unreached is pregnant women. So, pregnant women are the second group most at risk of malaria, second to children under age 5. And this has devastating consequences for both the mother and the baby. So the epidemiological kind of impact of malaria in pregnancy is listed on this slide, and for the sake of time, I'm not going to go into the details. However, if anybody wants the references, I have a reference slide somewhere. So I'm actually going to already switch to the next slide. So even though malaria in pregnancy is a major public health problem, particularly in sub-Saharan Africa, pregnant and lactating women face many gaps in terms of data on the currently on medicines gap. There are very few therapeutic options that are adapted to their use, timeliness gaps, and access gaps. The reason for this is because traditionally, there's been a reluctance to include pregnant and lactating women in biomedical research for fear of harming the fetus. So what this means is essentially we don't know if medicines that have been currently recommended for use in the non-pregnant adult population, if they're safe, these medicines, are they safe and efficacious? When used during pregnancy and lactation, we do not know. And so, so basically we need more research. Now, the good news is that the World Health Organization recently recommended artemether-lumefantrine to treat uncomplicated malaria in the first term of pregnancy. This was in 2022. But we still need other options to mitigate the threat of drug-resistant strains. And we also need more. There's very limited information on exposure during pregnancy to other artemisinin-based combination therapies. So essentially, we need more research, and this goes to show that when it comes to accessing the benefits of science, women have been left behind. So the MIMBA initiative aims to address all the gaps that I mentioned earlier. It is a holistic strategy that incorporates systematic change across the drug development cycle, starting from early discovery to access, to meet the needs of pregnant and lactating women in a timely and equitable manner. So MIMBA is based on 4 pillars. The first pillar is all about broadening access to currently used antimalarial medicines. Pillars 2 and 3 are about accelerating R&D for use of new medicines for use during pregnancy and lactation. And pillar 4 is all around advocacy. Because there have been calls by global stringent regulators to protect pregnant and lactating women through and not from research. But still, there needs to be work still needs to be done to raise awareness and shift mindsets around this. So in this presentation, I'm actually just going to be talking about Pillar 1. How does MMV work with its partners to broaden access to currently used anti-malarial medicines? So the first way is by collecting prospective observational data through pregnancy registries. Pregnancy registries have been established with our partners in Kenya and in Burkina Faso, and they are generating safety data on a range of anti-malarial medicines used to treat pregnancy, particularly in the first term. So these pregnancy registries are the only ones that we know of that are actively collecting information on anti-malarial medicines in sub-Saharan Africa. And they've also been set up so that they can be expanded to monitor the safety of other products, healthcare products used in low and middle income countries. So not just on malaria. And so these pregnancy registries will certainly provide a robust data source to inform policy guidance on the treatment of uncomplicated malaria in the first term of pregnancy. But they're resource intensive, and it will take a long time to gather enough to recruit sufficient numbers of women to gather enough exposures to have solid evidence. A quicker way to gather evidence on anti-malarials used in the first term of pregnancy is through interventional clinical trials. So this is why a global research consortium has come up with the idea of carrying out a global interventional clinical trial, and this month this clinical trial will start. So there's two things of note that I'd like to tell you about this clinical trial. It is the first adaptive randomized trial comparing different antimalarials in the first trimester of pregnancy. And that's interesting because this framework is useful to study pregnancy because it doesn't have a planned end date, and you can add or discontinue interventions according to pre-established rules. This allows to gain in efficiency and statistical power. The other thing I wanted to tell you about this research is that it adheres to the principles of equitable partnerships. So, for example, the capacity of our partners in malaria endemic countries has been strengthened to carry out these kinds of trials. The scientific gender balance has been achieved in the scientific leadership team, and there's also been an effort to ensure that the data emerging from this research can be locally owned, stored, accessed, and used. The last thing I want to tell you about to expand access to current antimalarials for use during pregnancy and lactation, MMV has been working with African manufacturers to produce quality medicines. Now, many of you probably already know that there is low coverage with chemoprevention during pregnancy as recommended by WHO. Only 1 in 3 eligible pregnant women actually receive the full course of treatment with chemoprevention during pregnancy. And the reason for this is because there are actually gaps in the quality of the sulfadoxine pyrimethamine used on the continent, and also often stockouts. There are gaps in the supply. So MMV has been working with African manufacturers to help them meet WHO standards of good manufacturing practice and pre-qualification. In 2022, MMV worked with a Kenyan MMV supported a Kenyan manufacturer to receive WHO pre-qualification, and this was achieved in 2022. And MMV is now working with 2 Nigerian manufacturers, and they're expected to achieve pre-qualification for sulfadoxine pyrimethamine this year, sometime in 2024. So by strengthening the capacity of African manufacturers to deliver quality-assured medicines used to prevent malaria during pregnancy, we expect to be able to fill some of the gaps in the supply and in the quality of these medicines. So I just want to thank you for your attention, and these are some of the partners that we've collaborated with on these initiatives. Yeah, that's it, and these are my references. Okay.
Thank you very much for leaving no one behind, a pregnant woman and their future newborn. Is there, do we have time? Yeah, we have time for one or two questions from the audience. Can't see in, yeah, no, I don't. Anybody? Maybe I have one question / comment. When you show 68,000 women pregnant recruited in the registry, it reminds me that it took the team in which I was working something like 20 years to collect that data registry, and yet the number of women with a confirmed malaria episode in the first trimester is small, and mostly confirm the fact that they've received the two most common treatment, AL for one and quinine for the other one. And so somehow I'm feeling a little bit disappointed in the sense that how long are we going to wait for, how long do we need to wait for pregnant women to be part of studies or analyses or whatever that they can they can be enrolled in studies or using drugs that everybody else is using, but they're not allowed to.
Thanks, Verena, for that comment. In fact, I totally agree with you. And when I mentioned that artemether lumefantrine has been recommended by WHO to treat uncomplicated malaria in the first term of pregnancy, that took 25 years to gather the data. And this was through inadvertent exposures. But I mean, it also obviously, even when you set up a pregnancy registry, which is prospective and observational, it will take a long time. Those pregnancy registries, I think, were established in 2020 or 2021. But it has taken a long time with 68, or actually, in fact, it's 65,000 recruits, but whatever, recruited women to gather 544 exposures to antimalarial medicine. So that's why the interventional clinical trial is essential, because we expect that with an interventional clinical trial, we'll be able to gather the information more quickly.
Thank you. Is there any more question, comment from the room? If not, thank you very much. Sorry, missed one.
Yes, actually, I think I might have a question. My name is Tijan Kuyate, and I am a student at the University of Geneva, the Masters in Global Health. And my question is, I would like to know if your advocacy also involves one around intermittent preventive treatment in pregnancy, because that is one program I believe is running in most African countries, and it helps to prevent malaria in pregnancy, especially in the first trimester. So you spoke about the artemisinin drugs, but I would like to know whether you are doing advocacy around this particular area, because one observation I have made in some literature reviews I have done is that pregnant women start the IPT, but they don't complete the 4 doses, and that still means the risk of malaria is still there for them during the course of their pregnancy. Like you have people starting the first dose, but they don't get to complete up to the 4th dose due to one reason or the other. So I don't know if you are doing any advocacy to enhance, the uptake of the treatment.
I love that question. Thank you so much for that question. So yes, indeed. In fact, our organization is working with the RBM Partnership to End Malaria through its Malaria and Pregnancy Working Group to advocate for enhanced uptake of IPTP with sulfadoxine pyrimethamine. And the campaign is called Speed Up, Scale Up. And in fact, I'm happy to tell you much more about this advocacy campaign offline, because I think we've already passed time. But yes, there are advocacy initiatives. They started off at the global level, then we moved on to the regional level, and now I know my colleague is working with African First Ladies through the OFLAD, Organization of African First Ladies in Africa, to raise awareness about the need to make sure that all pregnant women, all eligible pregnant women in sub-Saharan Africa receive the preventive treatment that they need.
Thank you very much for this precision, and thank you.
Thank you very much. And now, last but not least, I invite Dr. Lisette Schutte. She is project lead at PharmAccess in Amsterdam, and she's focusing on innovation, development, and behavioral change. Welcome.
Thank you. Thank you, everyone. And I know they're the diehards here. Thank you for your time and patience. I know the cocktails are calling, but I hope this will be an exciting presentation, that it will be done under 10 minutes. So today I'd like to talk about a digital solution to improve malaria surveillance in Kenya, Kisumu, that connects the private and public sector data. Now, we all know that an idea is only as good as its implementation. So you can have a wonderful innovation, an entire toolbox, but if it's not known, not used correctly, or in the long run, we're not going to have the desired effect. This is why in our project, we developed a project which is a test and treat approach for malaria that is designed to scale. Malaria, as we heard throughout today, doesn't seem to be going anywhere in any time soon. The aim was a 90% reduction in malaria incidence and morbidity by 2030 and an eradication by 2050. But if you look at the graph on the right from the Global Fund, the green line is what we are targeting. But unfortunately, the yellow line is what's showing what's happening now and what is predicted, which is stagnation in the reduction of malaria. And this is due to a multitude of reasons, from climate change, as we've heard, resistance to drug and diagnosis, low coverage of vaccine trials, and new mosquito variants that are resistant to, that thrive in dry climates. And that is not to say that we should stop our actions and initiatives. By all means, they're helping and we should continue, but we cannot continue with business as usual. We have to come up with innovative approaches that are efficient and that will accelerate progress. So back to our specific project. Well, the challenge and the issue that we're trying to solve is that, okay, malaria in Kenya alone, there were 4.4 million cases in 2022, 10,200 deaths. And the progress that has been made so far may be reversed due to climate change and increased resistance, as we've heard. There is no insight into private sector data. So in Kenya, 40% of patients in Kenya, they go to the private health sector as first point of care when they experience malaria symptoms, for example. But data from this sector remains underreported. And what often happens is that treatment is prescribed without testing, also in private facilities. And when you don't test, and you prescribe medicines, you might prescribe antimalarials for someone who doesn't have malaria but some other febrile disease. And that leads to overprescription and potential drug resistance at the population level. So what is a potential solution to this? Introducing connected diagnostics. This is a digital solution that aims to revolutionize malaria diagnosis and surveillance by connecting the public and the private sectors. What we try to do is stimulate testing before treatment. And the main aspect is that you digitize the malaria rapid diagnostic test for quality control and near real-time reporting. This is not only timely, but crucial at this point in time. The idea is to capture more data. Like I said, unlocking the private sector data, which is currently underreported, and offer this data on dashboards to policymakers, to decision makers, so that they can allocate resources there where they are needed the most. So what does the connected diagnostic solution actually look like? Well, we run a pilot in 5 private facilities that were enrolled over a period of 8 months, from May 2023 to December, in Kisumu County in Kenya. So how it works is that the clinician at the private sector will conduct malaria rapid diagnostic testing as per usual. However, the rapid diagnostic test is then digitized simply by downloading a mobile app on their phone that has been developed by our partner Odere. And this mobile app works offline, and it allows clinicians to take a photo of the malaria rapid test result, and AI in the back end will interpret the result as positive, negative, or invalid. The data will then be uploaded to a dashboard, which is made visible to the decision makers as well as the clinicians, so that you can see in near real time what percentage of tests at the facilities were positive, what were negative, and how many tests were conducted in total. So to stimulate this testing and the use of this mobile app, the clinicians are incentivized with data bundles for every correctly uploaded test. What were the results? Well, in a period of 8 months, 3,852 tests were conducted in the 5 private facilities. There was a 25% prevalence of malaria. However, this was not without the challenges, because we saw that only 33% of the tests were able to be identified by AI, because during the project there was suddenly a change in the stock of MRDTs being produced for which the machine learning hadn't been developed. But the good news was that the AI performance is comparable to human interpretation with a 95% accuracy. So what is the impact that we're having with connected diagnostics? Well, at the moment, you can see it as such. We are looking at the issue with one eye, right? Because yes, we are collecting data in the public sector, but this data is usually not up to date and incomplete because it's paper-based. By introducing connected diagnostics, we are complementing public sector health efforts, but for the first time, we're able to digitally look over the shoulders of these private sector providers and provide near real-time data. And as we know, diagnostics is the first step in a patient journey, right? You need to know what you have before you can get treated. So connected diagnostics allows us to identify the right disease at the right time and prescribe the right treatment. And this in turn allows decision makers and policy makers to allocate resources where they're needed the most, whether it's treatments, malaria nets, vaccines, because now they can see the true scale of the issue with both eyes. If this was easy, it would have already been done. So this was not without challenges in the field. The first was the procurement issue, like I said. The types of MRDTs used are procured by the national government and then are distributed at county level. And suddenly during the project, there was a switch. We had developed the AI for CareStart and BioLine, two types of MRDTs, and suddenly ParaCheck was widely available, for which no machine learning had been created. Secondly, data entry. As we know that rapid diagnostic tests are valid within a certain window of time. What people ended up doing because of workload, they piled up the malaria RDTs until the end of the day and then would photograph them one at a time. And we know by then they're no longer valid. And phone availability. Sometimes people are sharing phones within the facilities instead of each having their own phone in which the mobile app was downloaded. So if that person was suddenly sick that day, no photos could be taken. So what are our next steps? What are we focusing on? Well, we'd like to conduct qualitative research, of course, to understand the facilitating factors and barriers to adopting these MRDTs and the mobile technology. We want to update the machine learning algorithm to interpret all types of WHO-approved MRDTs. And we want to develop MRDTs that can detect multiple diseases in one, so-called multiplex tests that are DNA-based. We also want to expand this project with the funding and support of PMI USAID to decentralize care, actually democratize it by bringing it closer to the people, by now not only involving private facilities, but also the chemist around the corner who people go to when they experience malaria symptoms, as well as the community health promoters, as has been highlighted by the speakers before. This is and demonstration of what a potential dashboard would look like. So you can see each dot represents a healthcare facility. You can see the total number of tests conducted at that facility, what percentage of those tests were positive, which ones were negative. And based on this, you can create heat maps in real time, predict outbreaks, and distribute your resources, because surveillance is an important tool in the fight against malaria. And I'd like to acknowledge all my colleagues and the team, and in particular Felix, who did most of the analysis on this work. So thank you so much for your attention.
Thank you very much for your presentation. Is there any question in the room? Yes, there is one.
What about patient confidentiality? Like, do they have to sign something so their thing can be uploaded?
Yeah, thank you for that question. I know data protection is a huge deal. In this case, nothing is different. It's malaria care as usual, and even for malaria care, they don't have to sign any informed consent. And when it comes to this, we only generate unique test IDs, so no information is linked back to the patient, only to the malaria rapid test. So confidentiality shouldn't be an issue.
Another question? Maybe I have just one, sorry. Digitalization and AI leads to a high carbon imprint, and knowing that health systems need to reduce their carbon imprint, how do you see to address this dilemma? I know that it's not only your project, it's just how the world is going, but maybe we have really to think of that.
So are you saying that the digitization will increase the carbon footprint?
Yes, it does, because there is a lot of data there are a lot of servers that are needed to. I like these maps, and this is great, and for surveillance is very important, but still we have to think that how will we deal with that?
That's an interesting angle that I hadn't thought about before. I thought by going digital, we're actually being more green, because everything now is paper-based, and by digitizing it, you're uploading it. And we try to adhere to the existing infrastructures and systems as much as possible. And yeah, I think if anyone else has ideas, please
No,
feel free
it's
to
a dilemma
add,
that we all have, but I think it's very important to keep this in mind.
Keep that in mind, yeah, absolutely. Thank you.
All right, as we wrap up the session, I just want to ask you both if you have any key takeaways from all of the presentations, the 6 presentations that we've heard so far. In a couple of words, just in 15 seconds.
I think if I have to summarize everything that I have heard over the day and today in this session, is that we should. Yes, innovation is great, and we should continue to think about new items and new tools, but optimizing what is already existing so that we can make the best of it is something we tend to forget, and I think it's an important aspect of the work on malaria elimination. And I particularly like the work done in Guyana with very simple, basic existing tools, but done in an innovative way, because it reminds us that we can use the tools we have if we optimize their use.
Of course. Anything else, Blaise?
Yes, following just on that, I think I just wanted to make a link with the first session of the first day, and this is the last session of the last day. And I was very impressed by the person speaking about chemical pollution. And I think there is a tension between all our intervention in malaria elimination and environmental, because all these at the end go in soil and water. And I think we really need to know and prioritize the intervention that in the special context, they will lead to the least deleterious effect on the environment, and that's how we improve human health, animal health, while keeping our planet safe.
Excellent. Thank you so much. A round of applause.